Thank you very much. It's a pleasure to be with you this morning, and I just want to thank Bob and Ani for the kind invitation. With the presentation that Peter just gave us, he set the stage to the understanding of HPV, its oncogenic potential. And I really don't want to focus on these, just touch quickly on it. But I want to start with a quick outline of what viruses that cause tumors in humans. And this is just simply human tumors. And Peter described them. So the papilloma and polyoma, we know. The EBV and HHV-8, we know. And the hepatitis B, obviously, we know. So at least there are three big groups of DNA viruses that are involved in oncogenesis in humans. And obviously, the RNA viruses, the HTLV1 that was discovered a few years ago. So from the point of view of vaccines, and this did not really come because the etiology of the tumors was discovered, and consequently, the vaccine community went to make vaccines for that. I'll go over how these vaccines came to existence, but at least we have two currently available vaccines, hepatitis B that has been on the market for approximately 20 years now. The recombinant hepatitis B vaccine was developed in 1986, and the human papilloma virus vaccines, where there are at present two vaccines. One of them is available in the US, and the other is available in several other countries. In the pipeline, there are at least 2 or 3 big pharma companies that are pursuing an EBV vaccine, and probably some of the biotechnology companies. There isn't a lot more than this at this point, and in spite of the fact, I think it is a very attractive area from several points of view. Now, how did these vaccines come to existence? I mean, with all due respect to all the science that involves in trying to understand the oncogenesis from hepatitis B and from HPV, neither of those two vaccines came because it was a rationally designed approach to make vaccines. Both of them actually came out of serendipity. And I will focus for a minute or two on the hepatitis B vaccine. If you remember, the original hepatitis B vaccine was developed in 1982 in this country. The virus, the antigens were basically obtained from the blood of chronic hepatitis B carriers. And by the discovery of HIV, that vaccine was put to rest because nobody wanted to believe that whatever was in the blood in 1982, 1983 was inactivated by the process that the vaccine was produced, and that pushed the community, the scientific community, to go for cloning the surface antigen of hepatitis B. I'm prepared to argue that in 1981, 82, 83, in that part of, in that time frame, there was no specific evidence that the surface antigen that was circulating, whether it was the Australia antigen as discovered by Baruch Blumberg or all the subsequent evidence, that was the protective antigen. It was just a point, as some of my friends say, it was luck. This was a clear component circulating in the blood of infected carriers, of carriers and infected individuals. There was a reasonable sense that there is an epidemiologic association between protection from hepatitis B and the presence of the surface antigen. Anyway, the community went and produced a vaccine based on expressing, cloning and expressing the surface antigen in yeast. And the vaccine was tested. It turned out to be working, and we have been using it for the last 20-some years. So there was no rational design for that vaccine in any way, shape, or form. The same applies to the HPV vaccine. Again, two groups. Peter explained the structure, the molecular structure of the virus. From the beginning, it was clear that nobody wanted to work on E6 and E7 except to discover how they are oncogenic. Two groups, one in Australia and one in this country, went after cloning and expressing, and the first studies were cloning and expressing L1, the major capsid protein, and L2, the minor capsid protein of the virus. And one observation was the observation that led to the development of the two vaccines that we have today. The observation was, as the expressed proteins were coming out of yeast or baculovirus in insect cells, as was done by the group in Bethesda, the molecule self-assembled as virus-like particles. And that raised, at that point, in the early 90s, that raised the parallelism with the way the molecule of the hepatitis B vaccine self-assembled in virus-like particle, and it probably was the reason for its immunogenicity. That observation, both in Australia and in the United States, resulted into the two vaccines. Now, let me just go over what makes those polypeptides immunogenic. And I just want to focus here on the fact that the denatured polypeptide of the hepatitis B vaccine, of the hepatitis B surface antigen, and the denatured polypeptide of the human papillomavirus vaccine are not immunogenic and are not protective. So we have to appreciate here the complexity of the vaccine production. What made those two molecules immunogenic is the self-assembly. This is an electron micrograph of the hepatitis B surface antigen that is expressed in yeast. And as you can see, it is self-assembled into a virus-like particle where the surface of the particle is the surface antigen of the molecule. Inside that particle, there are host cells coming from yeast. So in a sense, when we claim, I'm talking now about the vaccine industry, when we claim we have molecularly defined antigens in the hepatitis B vaccine, it's a little bit less than accurate because there are still molecules from the yeast cells in the center of these virus-like particles. Not only that, what makes these particles immunogenic, and I'll go through this slide a little bit, is the process that the molecules, after being expressed by yeast, has to undergo at least 3 steps, which is cythianate treatment, then temperature adjustment, and then fully aged or fully mature molecules. And as you can see in the lower part of the graph, the maturation of the molecule from the point of view of the formation and the configuration of the molecule. And this actually parallels the immunogenicity. If you take these molecules here and use them for immunogenicity, they are very, very poor immunogen. As a matter of fact, they do not raise a decent antibody, and nobody will use them for immunization. Only these fully aged molecules that are used for immunization. So in a sense, what makes the molecule, the polypeptide, immunogenic is the self-assembly of those molecules into virus-like particles. This is exactly what was demonstrated when both Schiller and Lowy in Bethesda and Ian Fraser looked at the molecules coming out from expressing the L1, the capsid protein of human papillomavirus. Those virus-like particles were the first sign that the parallelism to the hepatitis B and the excitement about this could be a molecule that will be immunogenic and will result into a vaccine. As a matter of fact, because there is no animal model for human papillomavirus, the testing of this vaccine candidate was simply done in small animals, whereby the virus-like particles were injected into rabbits, and they found that these rabbits raised neutralizing antibodies. We don't really know that the mechanism of protection from that vaccine is neutralizing antibodies, but that was what made the whole community excited about the possibility of having a vaccine. And this is just the structure. It is, again, a very complex structure. The third element that has to be added for the vaccine to work is an adjuvant. And the vaccine that Merck produced, and I'll review that in a minute, has alum in it, and the vaccine that GSK has got a proprietary adjuvant. So with this background, I want to just give you an update about the Hpv vaccine and the Hpv and the vaccine. Now, I have one slide, and I do apologize to Peter and Arnie and all the people who are molecular biologists. This is a summary, but Peter has explained it completely for us, so consequently, I'm not going to spend any time on what is new about the function of E6 and E7. But I thought the question that Arnie raised related to why the oncogenic viruses have E6 and E7 that will drive oncogenesis, and the non-oncogenic viruses have E6 and E7 that do not. It is really a very, very important question. So we currently have two prophylactic vaccines, are made of the expression of the L1, the capsid protein of the virus, forming into a virus-like particle, and the expression in the case of Gardasil is in yeast, and in the case of Cervarix in baculovirus and insect cells. The quadrivalent vaccine that is called Gardasil, that is on the market here, has got 4 antigens. The L1 of Hpv 16, 18, both are responsible, between the two of them are responsible for approximately 70% of the cervical cancer cases that we see today, and has 2 other Hpv types, type 6 and 11, which are responsible for approximately 90% of the cases of genital wars that we see in this country. The other vaccine has only the Hpv 16 and 18. As I said, both vaccines contain adjuvants as a way to boost the immune response. Both vaccines are given in 3 doses. The proof of the efficacy of these vaccines was a major challenge in the beginning, because in a sense, the hepatitis B vaccine was approved on the basis of, would it stop hepatitis B infection? Would it prevent infection? And that was the study that was done in New York City, and that's the way the FDA approved the vaccine. As we were getting into the Hpv vaccine, the issue of how the utility of this vaccine to prevent cervical cancer is going to be assessed. And there were 2 groups of people that still, up to this date, debate the issue of what is the end point of testing these vaccines. So one group said, you have to prove that the vaccine will stop cancer of the cervix. And the argument against that was, this is an unethical study design, to have 2 groups of women, one of them will be given the vaccine and the other one will just sit watching until cervical cancer will happen. So in some ways, the FDA finally agreed that a pathological step that is known to occur probably almost 100% in cases that will develop into cervical cancer, and that is the intraepithelial lesions that can be demonstrated through pap smear and or DNA testing, that will be a marker for the possibility that the patient will develop into cervical cancer. And that's how the vaccine was actually finally approved. both in this country and the other vaccine that was approved in Europe. So the testing involved that you look into the SIN 2 and 3 related to type 16 and 18, and the intraepithelial, the adenocarcinoma in situ. And as you can see, this study involved approximately 30,000 individuals. The protection of the vaccine was 100% from the point of view of lesions that can be attributed to 16 and 18. For lesions that are not only in the cervix, but in the vagina, so this is vaginal lesions, the protection was 100%. Obviously, the number of these lesions were smaller. For any pathological changes in the cervical epithelium that is related to 6, 11, 16, and 18, and this is something that I didn't say before, that in spite of the fact that 6 and 11 serotypes are involved mainly in genital warts, yet some of those infections result into changes in the pap smear that does confuse the issue about oncogenicity or not. So when you look at the total lesions that occur in the pap smearing related to the 4 types in the vaccine, you get 95% reduction. And then when you look at the external, this is the external lesions like the genital warts and so on, you get 99%. So that was the basis for approval of the vaccine efficacy in this country and in the several other countries where the vaccine is today on the market. What is the duration of protection? And this is one of the more challenging issues. So by the time the vaccine, so this is antibody levels in the vaccinated population compared with the control populations. And as you can see here, whether it is 6, 11, or 16 and 18, antibodies get very high levels immediately after immunization. So there are 3 doses of immunization, and the levels are pretty high. And then followed by a stable antibody levels that can be detected up to 36 months. This study said that the vaccines are immunogenic up to 36 months. By the time the vaccines were approved in this country and in Europe, the group that was originally immunized had been observed for almost 5 years. So basically, we know that there has been no break cases of infection or pathological changes in the immunized population up to 5 years. So that gave a degree of comfort as far as the duration of protection from the vaccine, but it's not yet the degree that will give a degree of general comfort, particularly in the public health community. So the next step was to try to address the issue and the comparison again between hepatitis B and human papillomavirus is important in this context. We immunize infants upon birth for the first dose of the hepatitis B, and then there are 2 other doses in the first 2 years. And in some circumstances, it is recommended to have a booster dose in adolescent life. But basically, that's all what we do for immunizing against hepatitis B, and the general feel in the community that we prevented liver cancer this way, which may develop 20, 30 years. And if you look at do individuals that have been given the vaccine in the mid-80s, do they have a memory if they get exposed again to the antigens of this vaccine? And the answer is yes. Now, we don't have a similar situation in HPV, but what you have on this slide is an approximation, which is a population that was immunized and followed up for 5 years. And then they were given another dose of the vaccine. And as you can see, there is an anamnestic antibody response. Now, I want to be very careful here. We do not know the mechanism of protection against HPV infection in the immunized population. All what I'm saying is the immune system, as it expresses itself in an antibody response, shows evidence of memory and anamnestic response upon re-exposure to the vaccine 5 years after immunization. It gives a degree of comfort, but is not really a formal proof for anything at this point, except that probably there is memory. Probably there is memory. That's all one can say at this point. Now, the next issue that is facing us about the vaccine is both vaccines are against 16 and 18. So by definition, both vaccines can cover 70% of the cancers, of the viruses that cause cancer. Now, if you look at the etiology of cancer or the spread of serotypes in the population, you'll find that it differs by regions, so that's number one. And number two, the oncogenic group has got more than just 16 and 18. There is 31, there's 33, there's 35. So an attempt, because it looked from looking at the DNA sequence of these viruses, it looked that there is reasonable homology between 16 and 18, 31, 33, 52, and 58. So a couple of studies were done in the last couple of years about, is there cross protection by the vaccine that only protects or only induces an immune response against 16 and 18? Is there a cross protection against the other serotypes that are known to cause cervical cancer? So the panel here that is being tested is this panel that has got 31, 33, 35, 39, 45, and so on. And the point here is, in some ways, there is separation of the two curves between the immunized and the vaccinated and the unvaccinated. It is an indirect evidence. It's not the kind of evidence that everybody will want to say it is a definitive proof. And also, the protection is in some ways partial. So it doesn't really give a degree of comfort that this vaccine, 16 and 18 at this point, can actually protect against the other serotypes, and poses some very significant challenges on the pharmaceutical industry as far as the second generation vaccine, which I will get to in a minute. Now, the next challenge about the vaccine was, and still is, why was the vaccine only tested in females from the beginning? Because if you are an individual with a public health point of view, the only way we will interrupt the transmission of the virus in society is by immunizing a significant percentage of the community, so as we develop some sort of herd immunity. That significant percentage of the community, it depends on the R naught of the virus, but in most circumstances will be something between 80 and 90% of the population. So it cannot be done by gender-specific immunization. And the history of the Rubella vaccine in the UK is absolutely clear in our minds. When the UK originally introduced the Rubella vaccine to prevent the congenital rubella syndrome, introduced it only for adolescent women in England in the late 60s and early 70s. 10 years later, nothing happened to the incidence of congenital rubella syndrome. And that really was the drive for indicating that all of us have to get the rubella vaccine simply to interrupt the transmission of the virus in the community. That argument did not sit well with the FDA as we were going through the approval of the vaccine. And the issue was, unless you demonstrate protection and efficacy in a male population, the vaccine will not be considered for approval in that population. In spite of the fact that the Rubella vaccine was never tested in a male population. It was just indicated to stop the transmission. So this is a data that was presented a few months ago to the ACIP, whereby a study was done to examine the effect of the vaccine in a male population. And what it basically did is approximately 4,000 individuals that were in this protocol here to study, and they were followed up for approximately 2.5 years. And so the idea was to examine the vaccine from the point of view of its safety, obviously in a male population, and then its efficacy to prevent the incidence of HPV 6, 11, 16, and 18 related external genital lesions, because that was obviously the most evident disease manifestation in the male population at this point. We're not looking at prevention of cancers in the upper respiratory tract or anything like that. And the study was done in heterosexual men and men having sex with other men. So the way the study was done by examining the HPV DNA prevalence in the community and then do PCR. And this is just the background in the male population that was included in the study. Approximately 4% or so of the population has a prevalence of HPV 6. There is 1.4 HPV 11, and so on. The point is not similar to the female population that was originally studied in the efficacy of the vaccine. All of them at entry were proven to be negative for the vaccine serotypes. This was difficult to start a male population that was negative in any of these serotypes. And here are the results of the study. So for external genital lesions, the Gardasil group had 3 cases, and the placebo group had 31 cases, efficacy of 90% of the vaccine. And this is the confidence intervals. The second is the development of persistent infection, either detected by DNA or by the persistent infection. And the degree of efficacy, I'm just going to focus on this, for the persistent infection was 85%. For DNA detection, the degree of efficacy was 44%. What that says, therefore, is this vaccine can be a very, very effective tool in protection against the main manifestation of HPV infection. In this case, it would be type 6 and type 11 in a male population, and one can see an effect also on the persistence of infection. What are the remaining issues for HPV in our society? One is the issue of adolescent health. This age group, 15 to 25, which is in theory is the target age group for the vaccine, is a difficult age group because its interaction with the healthcare community is absolutely poor, if non-existent. Most of this age group interact with the healthcare professions only when they have an accident, when they have something that is absolutely acute. Other than that, contrast that with the wellness visit of the pediatricians, where the parents will take the kid every 3 months to get vaccinated. Consequently, there has to be some societal approach to dealing with it. In this country today, the age group 15 to 25, the adoption of the vaccine resulted in approximately 25% of that population vaccinated. I will contrast that for you with the UK. So the UK, a year ago, decided to introduce the HPV vaccine for the age group 12-13 in middle schools. By the end of the first year, by the end of 1 year, the 25%, by the way, in this country is a product of almost 3 years. By the end of the first year in the UK, 71% of the young females in middle schools were immunized. That reflects, in some ways, the societal attempt to have the coverage of vaccines reasonably available, and also because the vaccine is provided through the national health system, the economic barrier of the vaccine that some segments of our society here complain about has been at least taken out of the debate. The male immunization is going to come very soon now because the file is with the FDA, and already the commotion about it in our community, in our society, is really interesting, because it sounds like the public health community and the physician community have gone absent in action. Absolutely. I mean, simply because HPV vaccine deals with a sexually transmitted infection, nobody wants to stand up and say, this is the way we're going to interrupt the cervical cancer dilemma or the other cancers dilemma that we have in our society. So that just remains to be debated. The last issue is, obviously, 70% protection against cervical cancer will dictate that screening and pap smearing or DNA testing has to remain ongoing until we come to a point where the vaccine can cover more than just simply the 2 viruses that are responsible for 70%. So at this point, both Merck and GSK have announced last year that they're working on a second-generation vaccine. My guess, obviously, it has at least 31, 33, 45, and 52, but I don't know exactly what the coverage, but it will be absolutely important to come up with a vaccine that will get us close to 90% coverage. So it will become equivalent in some ways as a preventive tool to the regular screening, because there are still, even in this country, where it practices regular pap smearing better than any other community in the world, there's still segments in society, particularly the underprivileged and the underinsured and the uninsured, that do not get the advantage of regular smear and regular testing. So consequently, it would be fantastic if the vaccine will get us to a point where the coverage will be approximately 90%. That's all what I wanted to share with you this morning. Thank you very much.
Questions? Can we have the lights on, please, so we can see? Yes.
I understand that little is known about the mechanisms of Gardasil, of the function of the vaccines, but is anything known about functions that would be local, either IgA or cytotoxic T cell responses?
We really don't know.
There was a move afoot to be more social in their interactions than science here, but there was a move afoot by some legislatures in various states to mandate the vaccine for schools, which is very common. And then there was a move afoot not to as well. So could you just say a few words about the challenges of vaccines, especially venereal vaccines that prevent venereal transmission?
It's unbelievable unbelievable because in this country, we actually are the country that invented school requirement for immunization. And it was invented years ago because it was clearly the only way we're going to stop polio and we stop measles and we stop mumps transmission in this country. And to this date, you cannot have a child start primary school without evidence for immunization against mumps, measles, and rubella. Now, all these requirements are unfortunately because we are a federal government, but the state legislators are the ones in charge of the school system. So it has to be approved by every state at a separate session of their legislators. Now, all these legislations say it's a requirement. It's not really an enforced issue. There is an opt-out clause in the vaccination requirement. So approximately between 3 and 5% of the population don't get immunized because religious, because of philosophical, because of what? But 3 to 5% does not really disrupt the herd immunity kind of stuff. So this is the way we have been, and even the hepatitis B vaccine, which was labeled a little bit related to sex at one time, California mandated it in the late 70s because they found out the booster dose is reaching only 18 to 27% of the children in middle schools in California. They passed a legislation, and the following year, 71% of the kids were immunized. Now, all of this is the background. Come to HPV, and the commotion started. And the commotion started for two reasons. One is, unfortunately, so the governor of Texas decided to be a pioneer. And he said, I am going to mandate it in Texas by an executive order. And that was the end of it, because within a few weeks, his legislators met and said, forget it. So that's number one. Number two, there were attempts at different states to come up with school recommendations, and it got garbled for two reasons, or for three reasons. Half of us, and I'm not accusing any of you, half of us meaning the public health community and the physician community in this world, somehow or another decided that, what is the rush? Why is the rush to introduce the vaccine so quickly? Have you proven that the vaccine will stop cancer? Have you done this? Have you done, amazing things. One of them is one of the famous bioethicists at Penn. So I said to him, why didn't you write 10 articles about the approval of the rotavirus vaccine? Second day became a universal. All the pediatricians are giving our kids the rotavirus vaccine. Nobody is fussing, and nobody published a paper. And you published 10 articles about HPV. So he looked at me as if I'm a crazy guy. I said, well, because it's sex. It sells articles, and you can write about it. So half of us is that kind of population. The other half is what I call them the wise men and women of the scientific community, which is why so quickly? Don't you know that vaccines take 10, 15 years until you get it accepted and adopted? Well, tell that to a woman that will get cancer of the cervix in 5 years. That was always my answer. Tell that to your daughter when she gets cancer, and say, I was one of those wise men and women of the community that said, take your time. Does that give you a feel?
Yes. I don't want to address the rotavirus issue, but let me say, when I took immunology, I might have predicted that an IgA response on mucosal surfaces was going to be the response. I don't know which immunoglobulin you measured when you showed us the antibodies that last. Those are probably IgG in the blood. Has anybody followed IgA responses after the vaccine?
Not really, and simply because it's difficult to measure it. If you really want to measure it, you'll have to get cervical samples. And just, it was bad enough to say we will do smear to get cells to look into the virus, and not that much about the IgA. And again, some people said, how come you're dealing with a mucosal infection and you're immunizing systemically? So, I mean, there is that challenge. But it hasn't been done. I mean, in some ways, it needs to be done.
Yeah.
So this relationship between VLPs and these two instances is fascinating. Has anyone been trying to use this approach, even though it's empirical, for developing other kinds of vaccines to other viruses?
Two places. There are two scientists in the London School of Hygiene and Tropical Medicine that love VLPs, so they keep writing review articles that says, you know, the only way we can make vaccines in the future is to make everything in a VLP. I don't believe that stuff, but anyway, there is a company, actually, biotechnology company in Maryland, that is trying to structure the influenza hemagglutinin in a virus-like particle formation to see if that is immunogenic. Furthermore, GSK has a vaccine for malaria made of the circumsporozoite antigen. And that circumsporozoite antigen by itself is a very, very poor immunogen. So in the current formulation of the antigen, they combine it with the hepatitis B, and it forms a virus-like particle, and that is what's getting it to be a little bit immunogenic. And I mean, in some ways, it really challenges our reductionism, because we were fascinated. A monoclonal will get you a defined molecule, it will be a vaccine. And the answer is we have none. The only two defined are self-assembled.
Yes, Peter.
So the major burden for cervical cancer is actually in the developing world, and to have a major, it's the cervical cancer is the second most common cancer that causes deaths in women worldwide. But to have that major effect, it's a vaccine, an HPV vaccine is going to have to make it into the third world. The expense and the VLP process itself is going to be difficult to take into the third world because it requires a cold chain. I was wondering if you could say something about that.
I mean, you're absolutely right. 85%, 90% of the disease burden is out there. And out there, they have no idea about screening. So the best way out there would be a prophylactic vaccine. There's no question about that. I'm not concerned about the science that much, Peter, because our friends, the low-cost manufacturing capabilities in India, today provide Gavi, this is the Global Alliance for Vaccine and Immunization, with hepatitis B virus-like particles, 12 cents a dose in a multi-dose vial. Okay, so they have the technology. I mean, the question is, obviously, it's under patent at this point. What the global community has to do, and Merck and GSK, they have to wake up. I mean, they have to work on a model for introducing it. There are a little bit of noise about pneumoconjugate and AMC for pneumoconjugate, and the Gates Foundation is funding some trials in India. Merck donated 3 million doses, but we need more than that. I mean, and it's urgent. It's urgent. I mean, you can't really keep waiting.
Yes.
Maybe I missed it, but did you explain why the hepatitis B vaccine needs this three-step aging process to really be effective with immunogenicity? I was sitting here thinking it was kind of like wine. It has to go into a cask for 10 years before it's really good.
So the molecule coming out of yeast is partially self-assembled. But to complete the self-assembly, you need two steps. One is multiple disulfide bonds and some conformational changes that make the molecule a bit more rigid. And those two steps need potassium cythionate treatment followed by change in heat. I mean, I don't want to look like a manufacturing guy, but as a matter of fact, the Hpv vaccine, the guys at Merck will take the molecules coming out of yeast, disassemble it, and then put it back again. And when you put it back again, you get much more uniform particles rather than the haphazard reassembly of the particles out of yeast. So it really is a very, very sophisticated kind of management of the molecule to get it to, and we know the incompletely self-assembled hepatitis B is such a poor immunogen that it's an embarrassment. And it's coming out of yeast, and every one of us say, well, it's a molecularly defined vaccine, just use it. It doesn't work.
Yes.
I just like you to comment on the recent developments on the therapeutic vaccines, any vaccines targeting like E6, E7, or even E2.
There are several attempts. I mean, these two vaccines were tested to see if they can have a therapeutic effect, and the answer is no. So we know that. So there are actually several biotechnology companies today and some people in Australia that are working specifically to develop a therapeutic vaccine. Because, again, remember, you can prevent, but you still have a big age population with some lesions. And it would be fantastic if we have a therapeutic vaccine. There's nothing let's just say, there's nothing in phase 3. So if there is something that will come, it will take another 3 to 4, 5 years maybe.
So as somebody who worked on hepatitis B for 15 years, I have to say a comment about this issue of the aging and maturation of HBsAg. This is entirely an artifact of yeast expression. So you have to realize that HBsAg is a lipoprotein particle. It's derived from budding into the endoplasmic reticulum of multimers of HBsAg. And so that in addition to the polypeptide, there are lipids derived from the ER. And the lipid composition of yeast is very different from the lipid composition of mammalian cells. And that's why yeast particles actually don't correctly assemble. This wasn't appreciated in the early days of the academic papers, because after homogenizing the yeast, all these lipid vesicles would seal up into something that looked in the electron microscope like a particle, but in fact still wasn't completely disulfide cross-linked, et cetera, et cetera. If you make these particles in mammalian cells, all those processes happen normally in the ER, and the particles are then excreted by vesicular transport, and the stuff that is harvested from the medium is fully immunogenic as such and doesn't require any maturation, aging like a fine wine. So this is all an artifact of the phospholipid composition of the yeast endoplasmic reticulum and how it differs from the mammalian.
I'm glad that you are here, Don.
I think before we take a break, we should pay some homage, actually, to the man who first made a hepatitis B vaccine, Maurice Hillman, who was at Merck, whose vaccine actually came from people who were infected with hepatitis. And he then was so pleased that it was a good vaccine that he immunized Merck employees with that vaccine. And then they found out that most of those people had HIV infections. And so there was almost a rebellion at Merck at the time. But much to the credit of Maurice Hillman, who was an extraordinary man, who's probably the individual who's made the most vaccines, much to his credit, not a single person who was immunized with the hepatitis B vaccine, which came from people ever got HIV infection or AIDS. So the quality of the vaccines that Maurice Hillman made, and that vaccine didn't need aging because it came from humans. In fact, probably could have used a little aging, but it didn't. So we ought to pay some homage as we talk about vaccines to the gentleman who made the most vaccines of any individual ever in the world. So let's take a break. We'll come back at 11.